share at the end. And then I'd like to introduce Dr. Padia. Dr. Padia is an interventional radiologist at UCLA Medical Center. He earned his medical degree from Johns Hopkins. After completing his internship at the University of Hawaii, Dr. Padia began his residency in diagnostic radiology at the Cleveland Clinic, and he was chief resident there. He spent many years at the University of Washington, or 7 as he just said, before transitioning over to UCLA, where he is an associate professor of radiology. Dr. Padia is a very accomplished researcher, and he's a leader in the study of radioembolization, so we're very honored to have him speak on the subject tonight. He's a recipient of multiple grants and has over 60 peer-reviewed publications. He lectures nationally and internationally. And most recently, he's been the principal investigator of a study on genicular artery embolization. So with that, Dr. Padia will now talk to us about Y90 radiation segmentectomy. So I'm going to stop screen sharing and he can start. So welcome, Dr. Padia. And I just want to do one thing, which we've been doing at the beginning of these talks. Great. All right.
Thanks, Ezra. Ezra, can you guys hear me?
Yeah, I can hear you.
Okay. So thanks again for the introduction. I'm honored to talk to you guys today about something that's been very passionate in my career, that I've been very passionate in my career about, which is a modification of Y90 radioembolization called Y90 radiation segmentectomy. These are my disclosures. And just to give a couple of, some background issues, some background data on Y90, we've now really kind of incorporated as a lot of the standard treatment out in the standard treatment algorithms for HCC, although it's not necessarily in the BCLC staging algorithm. But when we do that, it's mostly been in advanced disease, patients with, bilobar, multifocal tumor, vascular invasion, and so on. And there's even some evidence in the setting of hepatic metastases, as we all know. When we look at this chart, and anyone who does an HCC lecture is obliged to show this BCLC staging algorithm, please note I've modified it here so that when we typically think about Y90, again, my disclaimer is the Y90, I added that in, we often think about it in the intermediate or the advanced stage setting, patients with vascular invasion, multifocal tumors. And this part, that left side of the chart, has been relatively stable, although admittedly RFA has been largely replaced by microwave and et cetera, and those are what's considered quote unquote curative treatments. And you'll notice in the red bar, that's 50 to 75% overall survival at 5 years, something to keep in mind. So when we look, why did the data evolve like this? Now I say contemporary results, but these, now that I look at it, it's not that contemporary. Riyad Salem published this 10 years ago now. This was the initial seminal paper for radioembolization where he did a prospective study, 291 patients. This was single arm. But the main thing to keep in mind is that at Northwestern at the time, they were still doing ablation for early disease, TACE for intermediate disease, and Y90 for intermediate to advanced disease. So you have all these patients with portal vein tumor thrombus, multifocal tumor, and then even half the patients had bilobar disease. And so you see their response rates in this advanced stage type of population, stratified by child A and child B. And so you're looking at response rates anywhere in the 60 to 70% range, which is okay, but it's not, exceptional. And then when we look at a bunch of different comparative studies of Y90 versus TACE, anyone who goes to, I would say, any IR conference in the last 5 years, there's always this debate of which one is better, and when you look at the comparative studies or when you look at meta-analyses, nothing really falls out, right? Like all of them show the same thing, that there's similar results, that their overall survival and the response rates are not that different. And so one would ask, if they're not that different, why are we using something that's more complex, more stressful, potentially more expensive, or at least that's the, what people feel, when we've been doing TACE for the last 15 to 20 years. And is it possible that a lot of these trials or a lot of these meta-analyses, what they did was they included all the patients. So what they, patients with early, intermediate, and advanced, and they put them all into the same boat to get enough patient numbers. And so, is it possible that maybe some patients in some categories benefit better with Y90 and some are benefit better with TACE? And so that's what we need to start teasing out. Now, everyone always asks, why don't you guys do a randomized trial? So again, at Northwestern, they did a randomized trial. They compared conventional TACE to Y90 for the mostly intermediate stage setting. In 6 years, they screened 800 patients. And in 6 years, out of the 800 patients, they enrolled 45. And for anyone who's been in a trial, who's participated in a trial as an investigator, it is super depressing to see those types of numbers. It's just, it's agonizing to screen and screen and screen, and no one wants to be on this trial, on these trials, especially in the U.S. And so after 45 patients, they had to terminate it. They didn't, reach their patient goal, which was around 250, but they did show longer time to predict progression within the Y90 group. However, same overall survival. Granted, it was not powered for 45 patients. So why is the convention TACE? Well, you take this patient, and throughout this, just keep in mind, I'm going to show a mix of data, a mix of cases, going from kind of easy or straightforward cases to more challenging cases, and we'll just kind of go back and forth from data to cases, so I kind of keep it fresh. So this is a 5 centimeter single HCC in the posterior right hepatic lobe, portal hypertension, transplant candidate if he can get downstage. And I would argue that most institutions in the United States and Europe would do a chemoembolization for this tumor, being at 5.1 centimeters. And so that's what we did. We did a chemoembolization. You could see the hyperemia, the hypervascularity in the middle DSA. And then you can see a very good, essentially complete response on the follow-up MR. So to me, at the 1 month MR, this is a home run. I'm patting myself on the back. But is this really successful? And so this is the 6 month MR. And now you see this increased nodular recurrence along the rim, compatible with progression of disease. And so the challenge with chemoembolization is that if you look at all the data, with time, there is a significant tumor progression rate. So I would say, in my opinion, the most rigid and consistent data has been by the Malagari group in Greece, where they've done a lot of prospective data on DEB-TACE and on Blandembo. And when you look at around 12 months, again, this curve on the bottom left compares DEB-TACE to Blandembo. And while I don't want to go into that argument, if you look at the DEB-TACE arm, they're looking at a close to a 50% tumor recurrence rate at 12 months. Okay, so that's why TACE is not considered quote unquote curative. The other interesting thing is that anyone who does chemoembolization knows that you have to do it often, multiple times. So if you look at how many times they did it 1 time versus 2 times versus 3 times, you're doing a bunch of procedures on any one patient. And of course, when I talk to patients, and I'm sure many of you, when I see them in consultation, I say, look, this is a process. It's going to take a couple of rounds for us to get our optimal results. So that's one of the challenges. The other challenge is that the data in portal vein tumor thrombus is not so good. It often requires multiple treatments, as I mentioned. And you often see this decreased vascularity after treatment. So this is an example of a patient who had gotten about 5 or 6 rounds of chemoembolization. And you could see that the vessels have become somewhat atretic, which makes any arterial-based therapy a little more challenging. What about ablation? So ablation, I would argue, is still the standard of care for 3 centimeters tumors or less, right? I mean, this is in every single guideline, 1 to 3 tumors, no vascular invasion, as long as they're well encapsulated, not infiltrative. Our group at UCLA, we've published several papers on ablation. I think one of the larger ones was to see if this could be pushed out to 5 centimeters. And this was well tolerated with relatively low rates of tumor progression. So this still remains the standard of care. And, again, it's, I think, partly operator preference, but the data seems to be kind of favoring microwave over RFA, although that's another discussion. So where did we come up with the super selective concept of radioembolization? If you are more selective, you treat a much smaller volume of normal hepatic tissue, right? So instead of a right lobe, you're treating segment 8 of the right lobe. So that makes sense. If you can increase the dose, instead of, let's say, 120 gray to higher than 200 gray, or even 400 gray, or even 1,000 gray, you can theoretically achieve complete response by essentially annihilating everything in front of your microcatheter. So when you combine these two concepts, a small volume of tissue and an accelerated dose, you can essentially do what's called a Y90 radiation segmentectomy. So this was our first patient. It was 2011, segment 6, infiltrative tumor. Again, the CT is a little bit washed out, but had vascular invasion, which you can see on the bottom right image. This was the right hepatic artery angiogram, and the microcatheter was in the right hepatic artery. And again, I don't know if you can see my mouse cursor, but the first branch coming off of the right hepatic artery was the segment 6 tumor. And we were doing lobar infusions at the time. And while we were doing lobar infusions, the patient snored or kind of coughed. And what happened was the catheter had bucked into the into that segment 6 branch inadvertently. And so what we did is we accidentally dumped all the microspheres in the segment 6 branch instead of the right hepatic artery, which was our initial intent. And so we had taken this right lobar dose and concentrated it into the segment 6 branch because, frankly, we messed up. And so what happened was the post Y90 Bremsstrahlung basically shows this hot ball of radiation in segment 6, but more importantly, there's no radiation in the other segments in the right hepatic lobe. So what had happened? We watched the patient. We were freaking out. We thought this patient would die of liver failure or have some horrible complication. But this is their scan at 6 months. You can see complete response. And again, this patient got treated once, one single radioembolization, and this is her 5.5-year follow-up. Not only is the tumor gone, but basically the rest of the liver has essentially grown in. So it looks like this patient has never even been treated to begin with. And again, this patient remained tumor-free for over 5 years. So what is our kind of technique on how we do this? So this is an example of a 2.5 centimeter tumor in the dome. Certainly ablatable, if not that easy, but this patient did have vascular invasion, so that's why we chose to do a Y90, which I'm not showing the PVT on this image, but it was there inferiorly. So we chose to do a radioembolization. So single tumor, segment 8, and this is our mapping protocol. So we do an SMA, and this assumes routine hepatic arterial anatomy. So we do an SMA run, look for a variance, look for portal vein tumor, portal vein thrombosis. We do a celiac angiogram, which you can see on the bottom right. Even though it's a right hepatic lobe tumor, we study the whole liver. So I catheterize the left hepatic artery in this case, do a full DSA to look for any other tumors or cross-filling from the left to the right. I then do a right hepatic artery DSA, and then you can also see that tumor blush in the dome of the liver. I do a cone beam CT, and I hope the video is showing on Zoom, but there's a cone beam CT here, a coronal reformat, which shows that hypervascularity at the dome of the liver. And then the final step is to do a segmental catheterization and do your angiogram there to confirm that you're able to achieve catheterization of your target. So the initial data came out in 2011. They looked at 84 patients over 5 years. Again, the definition's a little bit loose. So they looked at a looser definition of Y90 to 2 or fewer Quinault segments. And again, remember, this is a pilot study. So in this pilot study, they found an objective response of 81%. But also importantly is that the grade 3 and grade 4 bilirubin toxicities, which have typically been reported around 15 to 20%, dropped down to 6%. And with really no major complications. And their median survival, instead of like 1.5 years, was now 2.5 years. So this is the start. So how do we do the dosing? As you know, for radioembolization, there's 2 devices approved in the US. There's a 3rd device approved in Europe. The glass one and the resin one are really validated when you look at these equations. They're validated for lobar or large volume infusions, so right lobe or the whole liver. And what it doesn't really take into account is tumor hypervascularity, and it doesn't take into account that there's interaction between particles. So if you have a huge right hepatic lobe, you may not have some interaction. Of course, if you do it in a small area, you may have interaction between the particles, and we don't really know how that changes things. So the key thing is that these equations that we use to calculate dose are not designed for segmentectomy. They're designed for lobar and whole liver infusions. So how do we do this? This tends to be, admittedly, a little bit non-standardized. There's no magic formula. We do have a paper coming out in, it's in press right now, on like kind of an instruction guide on how to dose this. But if you're using the glass, which is what we typically do, the way glass TheraSphere works is that you start on a Sunday and it decays with time. Okay, so in the first week, it's hot. And then by the second week, like day 8, which is Monday, the second week, it starts to get cooler. So if you take, let's say, a 10 GBQ vial, which is here on the orange chart, which is 4 million microspheres, and you do it on Monday of the first week, it's super hot. But if you let that sit on the shelf for 8-9 days, it becomes cold. And so what we typically do is do these in the first week when the particles are super hot. And keep in mind that we are doing super selective catheterization and embolization. So the number of particles we need is relatively low. So we're not doing whole lobes. We're treating 100 cc's of liver. So you don't need 8 million, 10 million, 12 million particles. You'll end up going to stasis. So what we're typically doing are the 3, 5, or 7 GBQ vials in the first week. So they're relatively hot. Again, another case which is a little more challenging. This is a single focal tumor. Again, normally we would ablate this. The patient had this huge gallbladder and then had the colon stuck up under a liver. And she had like a bunch of abdominal surgeries and had multiple adhesions. So the surgeons who would treat her said, there's no way you're going to hydrodissect the colon. It's impossible. And we're not doing a laparoscopic or a surgical ablation either for that same reason. She's also Child-Pugh B, high bilirubin. So we thought this would be a good candidate for a segmentectomy. This is our celiac angiogram. And this is the right hepatic artery. You can see the one branch going into the segment 5 tumor. And we tried forever. This is one of those where you look at it, you're like, okay, this is pretty straightforward. It's pretty simple. We got our wire in, and for whatever reason, and we tried for like 2 hours to try to, we downsized our microcatheter. We could not get into this vessel, even though it doesn't even look that bad. And it's one of those where you keep on trying, you'll probably get a little bit of spasm at the origin, and just wasn't going to go. And you'll notice this is the first branch off of that right hepatic artery. So when we brought this patient back, we knew we couldn't do a selective catheterization here, and we didn't want to treat the whole right hepatic lobe. We put a 7 French RDC guide cath in the celiac artery. And then we put 2 microcatheters side by side through the guide cath, parallel to each other. So you'll see one has the wire in it into the right hepatic artery, and that has a balloon. So that's got a 4 millimeter balloon. And then we have the microcatheter, which is proximal to it, just at the origin of our takeoff vessel. And so then we inflate the balloon, and you can see the balloon inflated here. And now we're infusing in the trunk of the right hepatic artery, but the particles now have essentially nowhere to go except to ricochet off the balloon down into the segment 5 branch. And as a result, we're able to do a radiation segmentectomy by isolating the distal branches, and this patient had a complete response at 12 months. So let's go back to the data. So where are we today with radiation segmentectomy in terms of the data? And I won't go through all of these and bore you in detail I'll just kind of point out 1 or 2. So this primarily started at Northwestern, but now there's at least 3, if not 4 centers primarily doing this and reporting the results. Our group at UW and UCLA, you can see at the bottom. And you'll notice that with time, these are sort of chronological. If you look at the OR column, that's objective response, we've just been improving our technique over time. So now where we were getting 80, 85% objective response, we're now starting to get anywhere between 95 and 98% in terms of objective response. And many of these are complete response with long-term low tumor recurrences. You'll also notice that we've expanded the criteria. It used to always be less than 3 centimeters, try to compete with ablation. But now we realize that you can do this for larger tumors. So we reported even up to 8 centimeters in some of the later series. So I'm going to talk about the one we did. This was when I was at University of Washington, this was a single center study. It was HCC only. These were patients where transplant immediately, at least, was not available. They were not cancer surgical resection. And we felt that they were not ablation candidates based on clinical or technical parameters. In other words, it was usually the location, that it was not in an amenable location for thermal ablation. No extrahepatic mets, reasonable performance status. And again, I'm not talking about lobar TACE or lobar Y90. We're strictly talking about segmental treatments. When we did it over 3 years' time, this was 178 patients. You could see the number of tumors, a little over 100 in each group. They were relatively well matched. The ones in yellow are there where there were some discrepancies. So you'll notice maybe a slightly higher rate of child C patients in the taste group, but otherwise relatively similar. Again, this was segmentectomy or a selective chemoembolization, not lobar treatment. And when you look at the tumor characteristics, most of them had one tumor, but a lot of them had two or even three or four tumors. And so for the patients with four tumors, we were doing 4 radiation segmentectomies or 4 selective chemoembolizations. You'll notice that the median size is not that big, right? 26 millimeters, 32 millimeters, 3.2 centimeters, but the range was quite large. So we were treating up to 6 or 8 centimeters. So way beyond what is considered appropriate nowadays for ablation. The differences are highlighted in yellow. So this was our institutional preference. We felt that with infiltrative tumors, we get better results with Y90. So there was a institutional and physician selection bias for patients with vascular invasion and infiltrative tumors towards Y90. And similarly, patients who are already within Milan criteria where we were bridging to OLT, we just historically always did it with TACE. And so we kind of stuck with that. And so that's why you see those differences there. And so as with any study, you have to account for those differences. And we did a propensity score matching. This is a method to reduce the imbalance between 2 treatment groups. It's very helpful for retrospective studies if you have enough patients. So for example, we had more child C patients in the TACE group, more transplant patients in the TACE group, more infiltrative and more vascular invasion in the Y90 group. And this is a way to kind of correct the imbalances. In terms of the TACE, it was a little bit operator dependent, but the majority were with drug-eluting beads. I'm sure we could have an entirely different debate on oil TACE versus drug-eluting bead TACE, but it is what it is. This probably reflects real-life practice in most places. And you'll notice that 79% required a single treatment, and then the others required 2 treatments, similar to the Malagari data I showed earlier. For radioembolization, we used glass Y90 in all cases. The target dose was always treated to be greater than 200 gray, but in reality, we were going way higher than 200 gray. We were going 500 gray, 800 gray, over 1,000. There was a couple where we were doing 1,500 gray. Basically, it was as high as we felt we could go. You coil embolize the extrahepatic arteries like GDA and right gastric, but honestly, we almost never did that because you're so super selective. And again, we retreat if needed, but 93% of the patients only required a single treatment for their tumor. So a very small minority required multiple treatments. This is a patient that did require 2 treatments. So this is a single focal tumor. We felt it was too close for a thermal ablation because of the proximity to the common bile duct. You can see it on the axial and the coronal images in segment 4. This is the celiac angiogram. This is the left hepatic artery that you can see on the top left, and you can see some tumor hypervascularity. And then this is segmental catheterization of the segment 4 branch of the left. And I thought this is a home run, right? We can see this full perfusion, no problem. So we infused from there. This is the patient's follow-up MR, coronal image 2 months later. And you'll notice that the top third of the tumor still has this nodular enhancement. And on the delayed images, which I'm not showing, had washout. So what we do in these cases, even though we have some partial response, I go back and I look at my mapping, I look at my treatment, figure out, did I do something wrong? Was there something off? And what we noticed was that we missed something. So let's go back to the celiac angiogram here on the top left. And what we noticed was that off of the segment 2 vessel, that it was perfusing kind of the top cap of the tumor. And we had missed this vessel. So what we did is on this retreatment, we came back, we just treated this top 1 area. This was the segment 2 branch. And we got this patient at a 3-month follow-up back to complete response and a non-detectable AFP. So this is something where we had to course correct. When we look at our study, when we look at the toxicities, now keep in mind, you're super selective, right? So your liver toxicity in theory should be negligible. And when you look at the bottom half of this, the lab toxicities, which were grade 3 or grade 4, they were exceedingly low for both chemoembolization and Y90, right? So you're having a bilirubin abnormality of 9% in the TACE group, 3% in the Y90 group, which in all honesty is pretty much the same as you would probably get in a cirrhotic if you were to give placebo. So it really did not increase more than kind of the baseline cirrhosis population. You will notice that fatigue still occurs, right? So it still happened in 39% of patients. Despite the fact that we're treating small amounts of tissue, they still get the fatigue for a few weeks afterwards. Again, it didn't result in hospitalization, but it is an adverse event or a side effect that we tell patients. Okay, so more importantly, let's look at the response rates. And when we look at the tumor response rates, categorized into the standard 4 categories, and the ones we're always concerned about are complete response or objective response. And you will notice that the complete response rate was 74% for TACE, which is pretty much in line with most other studies, but it was 92% for Y90. And when you combine complete and partial, which is objective response, it was 97%. And this is really the highest response rates that we have ever seen for any hepatic arterial therapy. And it essentially exceeds most publications for even thermal ablation. And keep in mind, the patient population we're doing are a lot of infiltrative tumors, vascular invasion, larger tumors, et cetera. Of course, this is only one part of the story, right? So you want to get not only complete response, but you want it to stay like that. You want to kill a tumor and you want it to stay dead. So at 6 months, you don't want it coming back, like I showed in that earlier case in the very beginning. And so we looked at local tumor recurrence, and we looked at it for 2 years out. And the bottom curve is for Y90, and you'll notice that it's relatively flat over a 2-year period, where we have a really low tumor recurrence rate. And the TACE group was almost identical to the Malagari paper I pointed out to earlier in terms of about a 42% recurrence rate, which was pretty much the same. So we also looked at subfactors. Why did 10% of the tumors recur over 2 years? Tumor size had a lot to do with it. Actually, it's not 0, it's 1%. For tumors less than 3 centimeters, there was a 1% tumor recurrence at 2 years. These are some other factors which led to success. So nodular contour instead of infiltrated tumors, lack of vascular invasion, low AFP. These are favorable factors that we all know. So another example. So what we did was we took these single tumors. Now can we do this with multiple tumors? So this is a patient with 2 tumors. One in segment 4, you could see on the top left. And on the other 2 images, you can see this infiltrative, ugly-looking segment 8 tumor, which had vascular invasion. So this guy had a total bilirubin of 2.1. So he's Child-Pugh B. He has an AFP of 1900. So he's clearly not a candidate for surgical resection or thermal ablation in this case. This is his celiac angiogram on the top image, which is standard anatomy. And we're not, even though you have a left hepatic lobe tumor and a right, we're not doing left treatment and right treatment. We're doing segment 4 left, which is in the bottom left. And then we're doing a segment 8 in the bottom right. And we do this all at the same time. So the mapping and then the treatment is a 2-vessel infusion. Simmons catheter in the celiac, microcatheter in segment 4, infuse 1 vial, remove that microcatheter, put in a second microcatheter, select segment 8, put in the second vial, and remove that. And this is the Y90 bremsstrahlung. You could see, again, focal activity in the tumor, but there's nothing else in the remainder of the liver. This is 1 month, so has complete response at 1 month. His AFP drops from 1900 to 7. This is 36 months, so 3 years out, single treatment. And you'll notice that segment 8 lesion, it essentially looks like there's like an infarct. And this was read at an outside facility, and they didn't have the history, and they basically said that surgical resection has been performed in segment 8 because it essentially liquefies everything in that area. And his AFP was undetectable at that time. So we also looked at toxicity, we looked at tumor response, we looked at tumor progression, but we also looked at survival. And we got what we had hoped and what we had expected. So we had about a 6-month survival advantage with Y90, which you can see on the left side. So these were small tumors, so you can see that the survival curves are initially the same, but at around 1 year, they start to diverge. And progression-free survival, same thing. So we did see a PFS and an OS survival advantage. More recently, this was presented at CIRSE last month. This is a multi-center retrospective study of Y90, again, not necessarily segmentectomy, but for solitary HCC. This was done by 4 institutions, and it was about 160 patients. And the one thing to keep in mind is that the toxicities were extraordinarily low, and the absorbed dose to the liver volume, to the perfused liver volume, was in excess of 200. Now we're talking medians of 400 with an interquartile range of up to 800, right? So it's been done now in multiple centers. This is a nice study in that it shows collaborative data from 3 to 4 centers with relative similarity. And again, this is the Kaplan-Meier survival curve. So this is something that we would all want to see, in that you've essentially flattened out the KM survival curve out to 4 to 5 years, right? You don't see this big drop off that we've seen in the past. This is not perfect for everyone. So this is, there are a lot of challenges to this in many cases. So number one, this isn't always technically feasible. So the harder ones are the ones that are central tumors. They may not be good candidates. This is an example. This is a patient with a central segment 8 tumor. I thought I could do this, and it had a ton of feeding vessels going to it. This is the right hepatic artery angiogram. And yes, you do see tumor hypervascularity, but if you were to look really close, there are 6 different tiny little vessels that are all small catheter perfusing this. So I can't do a segmentectomy of this, even though I was hoping to. More patients goes to surgery. You're giving these super radiation doses. And what we found was that in tumors adjacent to the inferior vena cava, when they undergo liver transplant, there can be a lot of adhesion. So this is I took it from the operative note, and the surgeon is being kind in the operative note because at 3 a.m. he called me, he chewed me out and used more F-bombs than you could possibly imagine because he made a hole in the IVC and had quite a bit of blood loss. So that's one thing to keep in mind. This can cause adhesions to the IVC, and that's one thing you want if they're going to get surgery. You want to communicate with the surgeons. And the third thing are multiple feeding arteries. We've all seen this. Anyone doing hepatic arterial therapy has seen that not necessarily one vessel feeds one tumor, right? Especially the bigger or more infiltrated tumors. What happens if you have 2 arteries feeding a tumor, or 3? And so this is a case where it's a 5-centimeter tumor abutting the gallbladder. You can see on the top left where it's kind of squishing it. So for us, it's too big and not in a great location for an ablation. And so we did a radioembolization on this case. He also did not want a transplant ever. So we had to try to use something that we felt was definitive treatment. He had variant anatomy. So this is the celiac, where you have a replaced left hepatic artery. And this is the SMA, where you have a replaced right hepatic artery. And he had perfusion of the tumor from 3 separate sites. Okay, so the celiac on the left, there's 2 arteries perfusing the top half of the tumor, and the SMA on the right, an artery perfusing the bottom half. So what do? The goal is to treat each vessel. So 3 arteries means you order 3 vials, you treat all 3 at the same sitting. So as we go through this is the celiac on the left as your reference. And this is the middle hepatic artery. You see a falciform artery going down and in, and so we coiled that off. And so we're able to isolate the middle hepatic artery, and that we get very good tumor perfusion. So we're going to infuse 1 vial there. Again, the celiac on the top left, replaced left hepatic artery off of the left gastric, which you can see on the bottom left. So on the bottom left, we have a microcatheter in the replaced left hepatic artery. You can see all the gastric branches and so on. And then we super select the middle hepatic artery out of that. And you could start to see the tumor hypervascularity. It's kind of an early image. And again, so that feeds the top 1/3 of the tumor. So we're going to infuse our second vial from that position. So let's go to your SMA. This is the SMA replaced right. And that first branch perfuses the tumor. And that first branch, unfortunately, is the cystic artery. So you could see the oval-shaped gallbladder. And you'll notice that there's tumor hypervascularity coming out. And what we did was, where the microcatheter is positioned, we just slid it into the cystic artery, into that first branch where we were perfusing tumor only. So the non-selective cystic artery is on the top left, and the selective cystic artery is on the bottom right. So now we're perfusing essentially no more gallbladder wall and just tumor. So what does this look like at the end? We're doing a 3-vessel infusion, cystic artery on the top left, middle hepatic artery in the middle, and then the replaced left hepatic artery on the bottom right. So this patient got 3 vials. You'll see that uptake in segment 4. You'll also notice that there's no uptake in the rest of the liver. And this is the baseline on the top left, partial response at 1 month. And this is his 5-year scan. So he's got complete response. It's complete. That segment 4 is sort of scarred down. Again, 1 treatment for a 5-centimeter tumor, and he went 5 years. So what are some of the lessons or kind of things that we learned along the way as we're trying to figure this out. Number one, you have to do a cone beam CT on every single patient, even if you're confident that you're doing the right thing or covering the right thing. And we did this on 100% of the patients, and that really helped us, number one, get fast at doing cone beam CT, and it really should be part of the standard of care. Number two, when you're selective or super selective in this case, we kind of veer away from the 2.8 French microcatheters, and we're typically using small microcatheters, distal outer diameter 2 French, 2.4 French. And you'll often get spasms. So it usually injects some intraarterial nitro prior to the infusion. The dosimetry is still a work in progress, but we base a lot of it on arterial flow and tumor hypervascularity. So what do I mean by that? If you have a very small tumor, not very good flow, I pick a small vial, like the 3 GBQ. If you have a bigger tumor, or maybe vascular invasion, or maybe infiltrative tumor, I'll pick a bigger vial, like a 7 GBQ. And so you basically, we pick the 3, 5, or 7 based on tumor size and hypervascularity. And unlike lobar treatment, you can actually see the response at 1 month. And if you don't have complete response, then you can reassess. So in summary, I feel that doing a radiation segmentectomy is a potential leap in liver tumor therapy, where we're starting to get response rates and outcomes that we've not really seen with local regional therapy in the past. So what we've done is we've replaced TACE with Y90 in this specific setting. We still do a lot of chemoembolization. We just don't do it for segmental treatments. The nice thing is that radiation segmentectomy requires minimal treatments. You can use it in child B patients. We even do it in some child C patients. You could do it in patients with vascular invasion. Their hepatic function remains preserved. Their liver vascularity, their hepatic arterial vasculature remains completely patent. So if this patient develops another tumor at 6 months, you can do the same thing. We still need some more path data. I think that's kind of the reach that we're trying for the next 5 years. We also need to work on the dosing a little more. And we need to work on it for metastatic disease. So we just came out with that, and I'll show a little bit data on that. So where do I think that it fits in for HCC? Certainly in the advanced setting, again, we could argue about checkpoint inhibitors and so on, but I feel that we could start thinking about using radiation segmentectomy in BCLC-A disease. Now, whenever we think about A disease, we think, well, those should get ablated, right? Stick a needle in, just fry it, and you're done. And so this was data from our institution, which I pointed to earlier. On the left, this is the ablation data that my partners did from 2011 to 2014, size up to 5 centimeters. But one of the things to keep in mind is these are 2 separate data sets. So they're not to necessarily, I'm comparing them head to head, but it wasn't a head to head comparison. The major complication rate is 1. You can certainly have subcapsular hematomas or bleeding or bowel injury from a ablation. And so while it was still low, a 2% major complication rate is always something you want to be mindful of. The other thing is that a tumor progression was 10% at 1 year for tumors less than 3 centimeters. And that's basically what you're seeing for most papers worldwide for ablation. And that's considered, quote unquote, curative, right? And we're seeing for tumors less than 3 centimeters, we're seeing tumor progression rates in around 1%. And so if you're going to argue that ablation is curative for tumors less than 3, I think you can make the same argument for radiation segmentectomy. In terms of the complications, this is Ed Kim's group at Mount Sinai, same thing. When they did TACE plus microwave versus Y90, one case of biloma, one case of chest tube, one case of hematoma, and we've all know these are a pain in the neck to manage afterwards, right? So the nice thing is that with an arteriogram, you can't get a pneumothorax requiring a chest tube. You're not going to get a hepatic subcapsular hematoma. It's essentially impossible. This is one of our patients at UCLA, segment 2 tumor, who had been ablated, got residual tumor, so got reablated. And this is the scan a couple weeks after the ablation. So you can see this mess, this fistula coming out to the abdominal wall, and had a pretty terrible infection, had ventral hernia mesh here. And so that got all infected. And so this is unfortunately the downside of when an ablation goes wrong. The nice thing about a radiation segmentectomy is that this really should not happen because you're not violating the hepatic capsule. Nevertheless, we still do a lot of ablation in our group. So how do you choose, right? And this is admittedly as much an art as a science. So when do I favor an ablation? More central tumors, right? Not near bile ducts necessarily, but the more central it is, I think the harder it is to do a segmentectomy. When you can well visualize it on ultrasound or CT, and it's straightforward, I still tend to go for an ablation. And of course, patient convenience in the fact that an ablation is a single visit. For Y90, more peripheral, or let's say the subcapsular tumors, I think these tend to be easy for radiation segmentectomy and tend to be hard for ablation. Similarly, patients with vascular invasion, infiltrative tumors, your results with ablation are just not as good as someone without PVT. Whereas with radioembolization, this is really designed for this. Larger tumors, more than 3 centimeters, I tend to favor Y90. When you're seeing that MR and you see the tumor and then you have maybe some LR3 lesions, you're not sure what to do with them. Of course, the nice thing about doing a radiation segmentectomy is that you're doing an angiogram and you're doing a cone beam CT. So you can get better characterization of all these other indeterminate lesions compared to an MR or CT, which may help you guide the patient's treatment in the future. And of course, anyone who can't tolerate, we tend to do all of our thermal ablations under general anesthesia. So anyone who's not a good anesthesia candidate, I favor Y90. Over the last 6 months, I've tried to discourage GA because of COVID. And so that's kind of a night, for radiation segmentectomy, I'll do it with moderate sedation. And honestly, in many cases, I've done it with just lidocaine only with very good tolerance. Again, I want to just wrap up by one more case. This is a patient where I think a lot of people would ablate. Some people would do TACE. Some people would do Y90. So segment 2, it's a 2 centimeter tumor. So it does fit within the ablation guidelines. But if you look closely, it's up against the lung. There's stomach relatively close. There was colon just underneath it. So you'd certainly have to hydrodissect the colon. You'd have to deal with the diaphragm and the lung. This patient also, you can see the bunch of varices around it. They had a bilirubin of 2.5 and they had an INR of 2.0. Okay, so yes, an ablation can be done, but you got to think about what a pain it is to do the ablation, and it's a relatively high risk. You got to do a bunch of hydrodissection. There's a reasonable chance of bleeding, and so it becomes a little bit dicey. And in this case, this patient was listed for liver transplant, but for this patient's blood type, it was greater than 12 months. Celiac angiogram, we're common hepatic artery, left hepatic artery, segment 2 branch, left hepatic artery. And just look at the turns of the catheter. This is super, super easy. It's November. I could have one of my fellows do this and sit back in the control area, drink my coffee. They could easily do this today without any of my assistance. And this is a half-an-hour case, start to finish. This is the final post-Y90 Bremsstrahlung showing uptake in the tumor. Again, no uptake anywhere else. This is 1 month complete response, and on the bottom right, 12 month, and this patient got transplanted, and the explant showed complete path necrosis. Just gonna wrap up with segmentectomy for metastatic disease. Most cases, patients with like unifocal Mets or oligofocal Mets are typically surgical candidates, so we don't see them as much because they don't have cirrhosis. And a lot of these are hypovascular. So in these cases, cone beam CT is absolutely mandatory. The one thing is it's challenging to assess response. For anyone who's treated metastatic CRC, you can't really use modified RECIST criteria. You got to use kind of tumor progression rates. And the other thing to keep in mind for metastatic disease is a lot of patients may have had prior biliary procedures. So if they had a hepatic ojejunostomy, your infection risk greatly increases. This is a patient with Ewing sarcoma. So you have that calcification in their tumors, multiple prior lines of chemo, 2 isolated Mets you can see here, growing metastases. This is the celiac angiogram. You can see how small the arteries are because of chemo. But we were able to do a segment 3 on the top right, segment 7 on the bottom right. You can see the uptake in both those areas. And this patient had an excellent response for a long time out. Again, the tumors didn't shrink, but they didn't grow for at least about a year and a half. We recently published this. This is in press right now. We looked at 36 patients with metastatic disease ranging from colorectal cancer, neuroendocrine tumors, sarcoma, et cetera. And our disease control rate was over 90%. So we're able to at least confine the tumors in the vast, vast majority of patients. So this, yes, this can work in metastatic disease as well. And thank you very much.
Thank you, Dr. Patti. That was a fascinating talk. Thanks for joining us again. I have a couple questions, and then we have a bunch in the chat box too. And if anyone else has questions, please, you can type it in the chat box. I was curious, you were doing this at UW, and then you came over to UCLA. Was this being done at UCLA when you started, or did you have to change the paradigm, or did you help change the paradigm when you got there, and what was that like?
Yeah, so great question. So we were doing this at UW. It was not being done at UCLA like this. It was still kind of reserved for, Y90 was reserved for advanced cases, patients with advanced disease. And so we did have to change it up a little bit. So it was not, I'll be honest, like the first year or two, people meet it with resistance, right? Because they're like, why are you doing this for a 4-centimeter tumor? And so you just have to kind of push at it. And there was a lot of resistance in that first year to do it. But once we started showing our results, we showed them at tumor board, basically, individually discuss it with oncologists and hepatologists. Many of them have kind of come on board. What we've tried to do in the same setting, and I would advocate for everyone to do this, is not to just fixate on this one therapy, but just be the go-to destination, like your group or your group of physicians who treat HCC, to say, you send us the patient, we'll figure it out for you. Like, I don't want the hepatologist or the medical oncologist to say, man, does this patient need an ablation or a Y90 or a TACE? I don't want them to think that way. I want them to just send the patient to us saying, this patient has an HCC, and then you let us figure it out. And so that's how we've tried to change the paradigm here. And for the most part, it's worked, right? Because honestly, they don't want to have to figure this out. They just want you to treat them, for them to not get a toxicity and them to get a good response, right? And so that's what I have advocated for. All the consults are for HCC treatment, not necessarily for Y90 or for TACE or for ablation, et cetera. Again, we still have some work to do in that, but that's how we've been able to kind of be somewhat successful in this.
Okay. And then is your tumor board then reserved for more complex cases in that model?
Yeah, so it's a mix. So we have a relatively large system here in terms of geography. So that's one of the weird things about our tumor board. We cover UCLA Health. It has like tons of, centers. And so it's not actually possible for everyone to physically show up to tumor board or even via Zoom nowadays. And so I would say the majority of cases still get presented at our tumor board, but there is a minority of patients that just don't end up in tumor board because nowadays the geographic spread is too far. It's just not practical. And so that is something that we're trying to figure out. And it's an uphill battle. It's not easy.
Okay, great. Thank you very much. Artan Isa asks, when treating a liver with multiple tumors, say 3 and 3 segments, how do you calculate a safe dose? And then he says, do you use the same calculations that you would use for resection? So I take it like if you're destroying X amount of liver with your Y90 radiation segmentectomy, how do you think of that? So those are his questions.
So a couple things. So in terms of number of tumors and stuff like that, we've treated multiple tumors. So in a child A patient, I'll treat up to 2 tumors at any one sitting. So if they have 3 tumors, I'll do 2 tumors, and then I'll bring them back after a month, make sure they're feeling okay, and then treat the 3rd one. In a child B patient, I'll treat 1 tumor at a time. So if they have 2 tumors, I'll do 1, and I'll bring them back a month later, and then I'll do the other. And this is just kind of the algorithm we created to lean on safety more than anything else. And if they have like 2 vessels going to 1 tumor, we treat both vessels. You treat all feeding arteries all at the same time. They have 3 arteries going to it, we treat all 3 vessels. The dosing is a little bit more complicated. And so in some of the cases where the volume of tissue was really small, but there were 3 feeding vessels going into it, so you're dumping in 3 vials into a very small volume. If you're actually doing the calculations, like on the TheraSphere dose sheet, like with the actual volume imprinted in, it ends up being 1,500 to 2,000 gray. Our average was about, I would say, 900 to 1,000 gray, and our average of liver volume treated is 5.5%. So when you're comparing it to surgical resection, we're not even close to the volumes that surgeons are concerned about. This is way smaller than what most surgeons are concerned about. Of course, the reason why they're not surgical candidates for the most part is because of the presence of portal hypertension tends to be a near absolute contraindication for most centers in the US.
Okay, great. Thank you very much. And then Arjun also asked when would you use chemo embo over Y90? I know you touched on that a bit. If you could,
Yeah, so well, I'll give you two scenarios. So let's say in this setting, and again, this is my personal practice preference, and there's, again, it's an art, it's not a science, right? And we like at SIR and stuff have like, 2-hour debates about this. So in the segmental way, like I feel that when is taste better than Y90? Certainly where you have a short wait to transplant. So let's say someone's on the transplant list, they've got like 4 or 5 months. I don't need to get a 1 year, 2 year, 4 year durability. I'll probably end up doing taste. It's quick, get them in pretty fast, get them out, and so and I don't need like a 2 year, sustained response. And I don't necessarily, if I'm doing a Y90 today on November 11th, November 10th, I don't, and they get transplanted, next month, I'm not, I might be concerned about radiation issues with taste. Obviously, you don't need to deal with that. In California, we do have patients on Medicaid, which is called Medi-Cal. Medi-Cal doesn't pay for Y90, so unfortunately, they're not getting a radiation segmentectomy, they're getting taste. People who are not compliant, as we know, you order the particles, they show up, patient doesn't show up, my hospital's on the hook. So, where you have those patients who just tend to not show up, and again, it's a minority of patients. I say that ironically, I did have a patient not show up for a Y90 last Friday. So those ones I tend to do taste. And so there are some, I think, good reasons to do a chemoembolization. Patients with tenuous liver, where they're declining liver function, you may want to consider taste. And then in the broader sense, I'm still talking about segmental or focal treatments. If you're talking about lobar treatments, that's entirely different. We do a lot of taste for lobar treatments, multifocal disease, Child-Pugh B patients where Y90 may be somewhat, your adverse event rate you might be concerned about. And so I think there's a bigger role actually for taste in the setting of multifocal disease.
Great, thank you. Shams Iqbal asks, comparing with ablation, how do they compare in terms of costs?
So great question. We've looked at this, and there's a couple of things to think about. And you think, well, there's not that many cost papers, right? We actually did one internally, but then our administrators said you're not allowed to publish it because they didn't want the numbers coming out, which I found interesting. So the one thing about cost to keep in mind, are you talking, you always have to define what costs are. Are you talking about costs to the institution? Are you talking about the charge to the patient? Are you talking about average reimbursement, right, where they may have Medicaid, or they may have Medicare, or they may have Blue Cross Blue Shield, which all reimburse at vastly different rates? So the challenge is that the cost issue is largely dependent on how you define it. And then secondly, if you, any cost analysis has to include your hospitalization if you're keeping them overnight, the use of general anesthesia. And so in a recent cost analysis, actually it's not recent anymore, about 3 years ago, the Colorado group published cost analysis, ablation versus taste versus Y90, but they didn't include the anesthesia component in the ablation. And that makes up a significant component for cost. So the other thing to consider is this for cost. In our data, we showed that 70% of the taste procedures required one procedure. And in 30%, almost 30%, required 2 or more. And that's been replicated by other centers. For Y90, 93% required one procedure. In other words, one treatment. 7% required more than one. And so it's not just cost per procedure now, it's actually cost per patient year. Because if one patient gets 5 TACEs, and then the next patient gets 2 Y90s, even if the Y90s are double the price, it's still cheaper. And so because there's so many variables like this involved, it's exceedingly difficult to do. What we've seen is that the costs in general are not outrageous. They're not as expensive as everyone hails them out to be. And frankly, today with checkpoint inhibitors, let's say atezolizumab plus bevacizumab, which is the standard of care for HCC, is $250,000 for 1 year. So it pales in comparison to the cost for systemic drugs.
Okay. It's amazing how something that seems like a simple question is incredibly complicated.
Well, I thought it was a simple question too. And then I tried to do a project on it, and then it got so complicated, we gave up. We threw in the towel because I had no idea how to do all this. I mean, the cost thing was just so chaotic.
Okay. Dr. Iqbal also asks, is there an upper limit is there a highest bilirubin that you would do a segmentectomy for, given that very little tumor is involved?
Yeah, so we didn't, the highest I've done is a bilirubin of 6, and that sounds crazy, which I guess it is, but two things to keep in mind. As long as the bilirubin, a stable bilirubin is way better than an increasing bilirubin. So I'd much rather do a guy with a bilirubin of 3, which has been 3 for the last 6 months, versus a bilirubin of 2, which was 0.5, 2 weeks ago. So you don't want to just look at, you don't want to just look at just the absolute number. The other thing to look at is your albumin. A lot of people are using the ALB score. So your albumin, if your synthetic function is good, you could probably get away with a higher bilirubin. A bilirubin of 3 and an albumin of 1.8 is terrible. A bilirubin of 3 and an albumin of 3.5, not so bad. So we've stretched it to patients with bilirubins in 4 and even 5 for radiation segmentectomy specifically, but those are patients who are stable and they had good albumin, so they had good synthetic function. And so in those cases, you can get away with it. It's just that the ones, you have a bilirubin of 4 and you have an albumin of 1.8, I think you have to be careful doing any liver-directed therapy. That patient's going to tip into failure. So I know someone asked about Serospheres, and I did talk about TheraSphere. I do think that 2 years ago, I didn't think it was possible with Serospheres. I think that one of the challenges with using resin microspheres is that your particle load is too high. So, the average vial comes in 3 GBq, and it's the labeling is 40 to 80 million particles. So it's about, let's say 40, lean on the safe side. So let's say 40 million particles for a 3 GBq vial. So it's a lot less dense, right? So when you're doing these small volumes, you'll just go to stasis if you give that, and that's a problem. They now have, for those of you who use resin, now with the flex dose, you can do, essentially ones that are called 3-day pre-cal, so they're much hotter. And while it hasn't been validated for segmentectomy, I think it's possible to do it with radiation segmentectomy if you start thinking about using the 3-day pre-cal vials, which tend to be more concentrated with radiation. Again, there's no data out there, unfortunately, for Serospheres and radiation segmentectomy. I believe there are 1 or 2 groups working on it currently.
Well, I think that's it for questions right now, unless anybody has another question. And if not, we'll go on to case presentations. And Dr. Padia, basically we have the presentations, and then we ask for you to award a best case award afterwards, and that person gets an engraved pen. I think unless Dr. Halen wins, because he is on the board, so I'm not sure if he can get a pen. But
can I ask a question briefly?
Oh yes, of course.
So Dr. Padia, we have people with various backgrounds here. It seems to me one of the keys to success is that you have to be very facile with your arterial anatomy of the liver and the abdomen. How did you gain confidence in this when you were starting to get into this realm? Is that a reasonable question?
Yeah. So I think 2 things. Number 1 was volume. And so if you don't do a ton of it, it is harder, just like I think anything in, any complex thing in IR. I kind of took a liking to this. So I studied it a lot. And there are, now at least a half dozen papers in JVR, CVR, and so on, which describe arterial anatomy. And I studied them. I studied them a lot. And I mean, some of the, I keep 4 reference papers they're basically encyclopedias of arterial anatomy there. And in the beginning, I highlighted and I went through each paper probably 10 to 20 times. I spent a lot of time on it. And then with each liver angiogram, whether it was for a trauma, whether it was for a Y90, whether it was for a TACE, I'm always, trying to figure out all the vessels, whether it's important or not. the key thing I think that for, especially for trainees, for the residents and fellows, what I would encourage you to do, every single liver angiogram you do, I want you to look for your GDA. I want you to look for your right gastric artery. Those are the two most important extra hepatic vessels that you want to identify. The GDA should be relatively easy. But if you start looking for the right gastric artery on every single case you do, even though if it doesn't matter, by a while, it becomes kind of second nature once you start doing it enough. And if you're just trying to find it for the first time, it becomes really challenging. So I just kind of trained myself to basically continue to repeatedly look at this over and over and over again. And just like anything else, it just took practice.
Great, thank you. Any other questions? Okay. Dr. Halen, do you want to present your case?
Sure, if you want me to go first. I don't know if you want to let the trainees go first.
All right, we can have, if you want to go last, we'll have them go first then.
Let's let the trainees get their cases out of the way, and then we can have my fun case.
Vincent, do you want to present your case then? You can screen share.
Hey. Yeah, sure. Give me a
Perfect.
sec. All right. Good evening, everyone. I'm Vince. I'm one of the fellows at MGH, and appreciate the opportunity to talk about this case. So I have a 67-year-old with a MELD score of 11, past medical history of cirrhosis, secondary alcohol and NASH with recurrent ascites. And the patient had a primary TIPS placed back in 2018. Since the TIPS was performed, the patient had been doing well without requiring repeat paracentesis. And about a month before presentation, the patient began having progressive abdominal distension and pain. And initially presented at Outside Hospital, was worked up, had recurrent large volume ascites, and basically transferred to MGH. Let me just show the next slide here. So this was the primary TIPS that was done back in 2018, and you can see, this was the initial pigtail run, and this screen right shows the TIPS, and you can see there were overlapping TIPS stents. I think it was because the first one was not long enough. This was post-dilated to 8 millimeters, and the pressure gradient went from 19 to 10. And at the same time, during this procedure, the patient also underwent a splenic artery embolization to further decrease the portal pressures. So this was the CT done when the patient came to us. Let me just scroll down to the important part. So as you can see, there's large volume ascites. You can take a look at the TIPS stent here. It's not opacified by contrast, and you can see sort of a filling defect here. So there's the TIPS is basically occluded with a thrombus extending into the main portal vein. That's the splenic artery embo, and you can see here, this is sort of a IMV, a very prominent IMV that's leading to a large varix, and the varix sort of connects to the IVC, and this is just a coronal view showing the same thing. We see an occluded TIPS with thrombus in the main portal vein, and then you can see this large IMV varix shunting blood away into the IVC. So the patient came to us, and then for a TIPS recanalization, basically, we start right IgA access, we put a 10 French sheath down. We try to cannulate it from above, but we were unsuccessful in doing so. We use a bunch of different catheters, reverse curve, Compi. And the issue was that if you look here, the TIPS stent is kind of protruding into the IVC. And we're guessing that there's probably flush occlusion. You know, we did a venogram here to see if we can maybe find a stump, but we were unable to do so. So there's probably flush occlusion of the thrombus. So that's when we decided to stick the TIPS stent directly, transhepatically, and doing a direct puncture. And this is just an ultrasound. We did a para first to drain the ascites. And then we just went in with a NEF set. We used a 21 gauge Chiba needle to stick the stent under ultrasound. And this is the initial puncture into the stent. And then we passed the 018 wire and then, exchange the needle for, we tried to use the NEF set, the introducer sheath, but it wasn't stiff enough. So we actually used like a stiff micropuncture sheath to kind of get the sheath into the stent. And we were having trouble using the floppy end of the 018 wire to get through the thrombus. It was likely a fibrous cap here. So we eventually used the back end of the like a V18 wire to kind of puncture through the fibrous cap. And then once we punctured through the fibrous cap, we were able to advance our introducer, the sheath. And this is sort of a run showing that we're inside the IVC. We went from above and we snared that V18 wire. And then, once we snared it from above, we had to run through access. The next step is to try to get a wire or some sort of catheter down into the stent from above. So we did some gentle angioplasty of the fibrous cap so that we can pass for devices. And after the angioplasty, we're able to get a accompanying glide wire down and through the stent. And as you can see here, there is the TIPS is occluded with a filling defect here. And we plastied up to 10 millimeters. And even with the balloon maceration, we were still having the basic thrombus. So then we used an angiojet to like an 8 French angiojet catheter. We administered 4 milligrams of TPA, and then we did thrombectomy. And then this is what it looked like after the angiojet. We then turned to this IMV shunt because this was going to cause an issue because this is so big and there's so it's basically shunting blood away from our tips. Even if we recanalize the tips, there's a risk of reocclusion because of the shunt. So we just went down with the compy, and then we basically coil embolized with a bunch of coils, O35 coils, and then we turned to the tip stent, and then we relined it basically with a long 8 centimeter Viator, and then we post-dilated to 10 millimeters. And after we relined the stent, we did a repeat run of the IMV barracks, and you can see there's still incomplete occlusion. So then we, at this time we already spent so much time on this case. We decided we should just finish this off, make sure that this is completely occluded. So we injected glue, basically, and BCA and Lopidol mixture into this barracks, and then here you can see there's complete occlusion. And this is our final run. You can see the tips is patent now. The patient was placed on anticoagulation, on heparin, and then we repeated the tips ultrasound about 4 days later that showed patency in the stent. So, this patient was discharged on warfarin, and then we're going to repeat a follow-up ultrasound in about 4 weeks. Any questions?
Well, thanks, Vince. That's an excellent case. Very challenging case, and it seems like it did take. There was a lot of steps to it. Very impressive. Any questions from anyone about that case?
I thought that was a very good use of the transhepatic route to get into the shunt. My only question was, I just didn't catch why they embolized the splenic artery in the first tips. Was there some massive gradient, or what went on to do that? Because you decreased your driving gradient to keep the tips open by doing that. I wouldn't usually be embolizing the hepatic artery and putting a tips in at the same time.
Yeah, that's a great question. I think you know, at the time, the staff that performed the initial procedure, they weren't there, so I was unsure actually. But I believe it was to reduce the portal pressure. But
I mean,
yeah, like you said,
just
yeah.
as a you know, as a point, you might want to tend to not decrease your gradient too low. You know, leave it a little. Maybe you might even leave it a little bit higher, let it settle out, see where things go. But you know, you saved it, and hopefully now this will stay open. And it looks really nice. And thank goodness we have covered stent grafts for tips, right? Cover the hole in the that you made in the shunt when you got in there.
Yeah, exactly. You know, initially we were afraid to, put a big sheath in there because of the hole, but then, you know, we realized that we're going to be putting in a Viator anyways, and it's going to cover up that hole.
Right,
Good
because
point.
in the early days before covered stents, or when we had a very bizarre diversion to wall grafts, bile intravasation was the major cause of acute thrombosis. So you solved that problem by just covering over it. So it's a good case.
Great.
All right, thank you.
So next we have Jaleel Konteri. Jay, you can screen share and present your case.
All right.
Vince has to relinquish control. There it goes.
All right. Can you guys see my screen? Hello? Yep. Okay. Perfect. Yeah, my name is Jaleel. I'm one of the IR fellows or interventional radiology independent resident at Brigham and Women's Hospital. I have a case from my last year that it was a treatment of the IVC, inferior vena cava pseudoaneurysm, using endovascular balloon-assisted thrombin administration. So my case is about a 71-year-old man with history of traumatic brain injury and had a prophylactically replaced titanium greenfield IVC filter in 1990. And presented with abdominal pain that was correlated with the IVC filter. The patient was adamant to remove the IVC filter. So pre-op evaluation, we pretty much can see that there is moderate caval stenosis with approximately 40 degree apical tilt. The apex is probably embedded around here with perforation of the two medial struts through the caval wall. So it's pretty close to the aorta and the, close by lumbar artery. So as part of the, following up in the chest, we noticed that there's occlusion of the right brachiocephalic and bilateral IJ, making this case just more complicated. So first thing first, we needed to recanalize the right brachiocephalic and IJ. So we started with the 8 French 45 centimeter flexor sheath via the right common femoral vein. Use this glide wire and hydrophilic vert catheter to recanalize the right brachiocephalic vein. And then we pretty much found this collateral jugular vein that we were able to opacify. So then we exchanged that catheter to Amplatz 50 millimeter Amplatz gooseneck snare. Fluoroscopically targeted that snare with a 21 gauge micropuncture. Passed on the V18 wire through that and pretty much snared it down through the IVC. So now we have a through and through access that was established and exchanged it to the Amplatz super stiff wire. balloon the brachiocephalic and the collateral jugular that we pretty much access using a 10 millimeter Mustang balloon. And pretty much now we're able to accommodate a 16 French sheath from the neck. So moving to the fun part of this thing, now going to the IV series pre-roll part. Now that we have the access, we pretty much were able to dissect the struts, retrieve it as a single unit using a 9 French endobronchial biopsy forceps. You can see, we were able to get the, tilted apex and get it all in one piece. So everything is great until we do the venography. We do the venography, and as you can see, there is active extrav or pseudoaneurysm at the area that we had the strut. So we went to the IVES, and you can see, let me see if I can minimize that. There is a defect on the wall. So it really nicely correlates with where we're seeing the active extrav. So first thing first, as many of you, might consider, is just doing a balloon tamponade. So we've held it up for 15 minutes and then was not really successful. So the next step was flow diversion. So use the 18 by 60 millimeter wall stent in the infrarenal IVC, followed by 5 minutes of balloon tamponade. And the pseudoaneurysm continued to fill out, as you can see here. So at this point, we decided to go in and do the endovascular balloon-assisted thrombin administration. So use the glide wire and NaviCross catheter to cannulate the pseudoaneurysm. Put the same balloon up again, and now we're excluding the NaviCross and injected 500 units of thrombin through the NaviCross. After 5 minutes, check the IVUS, which showed the pseudoaneurysm has now thrombosed. And this is the final venogram. So now we don't see the contract extravasation, and the IVC is patent. Follow-up, patient discharge on postoperative day 2. Also, his abdominal pain was resolved. 5 months follow-up. The time of making this presentation, also patient had no abdominal pain, and the CT scan showed that the IVC was patent. So a couple of points, there are more complications with IVC filters that have been there longer, especially, with some 70% retrieval filters, 15% with permanent filters. The point that I want to get here is that, with advanced techniques, we are able to retrieve them. It can go up to 96% success rate. But then, you wonder, you have the pseudoaneurysm as one of the complications, like in this case, and it's a matter of conservative management versus balloon tamponade. And in this case, I guess I wanted to put it together. Some might say, why not just put a covered stent? It really comes down to, how much you want to, be financially, you want to save money for the facility. And I think this was a way to kind of save that rather than using an expensive covered stent. So the last thing I want to say is that the last, the longest filter that has been removed, at least as of the time that I was making this presentation, was 19 years ago. And today's case is a 29 years old filter. And that's about it. Any questions?
What was a patient like clinically when you discovered the defect in the cava? Were they stable? Were they unstable?
They were stable. Yeah, they were stable. It never got to a point of getting tachycardic or anything like that.
How long did it take from the time you just found the defect to the point where this stent graft was deployed successfully?
From the defect until the pseudoaneurysm was not filling anymore?
Yeah, yes.
Oh, yeah, I would say probably like 45 minutes, 30 minutes to 45 minutes.
Thank you.
Yeah.
Great. Any other questions? Okay, thank you. That was another great case. Thank you for sharing and putting it together. also very complicated. Did his IJ stay open, or that collateral?
Yeah, that collateral. So the brachiocephalic was still patent, but that collateral, no. I mean, we didn't really evaluate it, but we, on the CT, I couldn't find that collateral anymore. But the brachiocephalic, yes, it was still open.
Great. Then I guess that's it for our first two presentations. And I guess, Jay, if you stop screen sharing, then Dr. Halen can present.
Why don't we let Dr. Padilla choose the pen
Perfect. That sounds good.
owner here?
All right. Well, in that case, Dr. Padilla, you can select the. Oh, we see your baby.
Yeah, I'm on baby duty now, but
Junior resident.
yeah, you can't. I'll give it to Jaleel on that last case. Good job.
Congratulations, Jaleel.
Thank you.
Okay, congratulations. I have a, this is just a case from the other day that's very interesting that shows how simple things can become exceedingly unsimple. Let me see if I can succeed in sharing this. Okay, so this is a case of, I call it the case of the leaky spigot. And sometimes you just feel a little raptor. So this is an EVAR case from not long ago. 57-year-old male, history of AAA. It had bilateral internal iliac aneurysms. His right one had been coiled and stent grafted over. And so there was a stent graft in his right common iliac. It was a Gore EVAR limb, so an iliac limb. The guy was a mild train wreck, coronary artery disease, multiple cabbages. His LED was occluded, and he had signs of ischemic cardiomyopathy. He had hypertension, hyperlipidemia, paroxysmal AFib, prostate cancer, gout, and had a pacemaker, which for this procedure was set to a steady non-demand rate of 80 beats per minute. And so this is just some planning CTs that were done, showing a relatively short neck, not terrible. I mean, on this view, it's much better. Bunch of angulation. Of note, this is the prior stent. So this is a 16 millimeter limb that was in no way expanded to 16 millimeters. And here it is sticking up into the iliac with that angulation. And then you can see here it is kind of swimming in that iliac, native iliac, and then this is the left common iliac, and then this is the left internal iliac over here. And this is the attack of coils from the prior embo. So there was a lot of discussion at vascular conference about staging. We wanted to fix the internal iliac aneurysm as well as the AAA. And there was a lot of discussions. He already had his right side emboed. Should we embolize the left side, wait before doing the EVAR, or do them both at the same time? And eventually it was decided we were just going to plow ahead and try to do them at the same time. There was a lot of discussion whether we were going to try to embolize it from the left or the right. We chose an Endologix Alto device, which is their new device. The plan was to stent over the embolized left internal. And just for people who haven't seen this, so the Ovation graft, the original Ovation's on the right. This is a device that just has metal at the top, the crown, and then it's held in place by these sealing rings at the top. The polymer fills these little rings down here where you stick in the extension limbs. And then the extension limbs are very conventional. This is the original device, and you can see that the fabric extended up here above the sealing rings and into the metal crown. This is the new device, which has the fabric end right at the bottom of the crown, and the sealing rings have been moved up. Another key difference between these devices is when they made this change, this does not open by itself anymore. This device actually has an intrinsic balloon that's used to expand the bottom of the crown to seat it. So we thought the first thing we would do, just to make sure everything worked well and sat well, would be to try to fully expand that existing stent. So here is the existing stent. We put in it's a 16 millimeter limb at the top. It was extended with a Viabon at the bottom. So it's 10 down here, it's 16 up here, and it tapers down. So there's the balloon. Ping. We felt we opened that up a bit. The previous coiling was done by vascular surgeons, and they were on an austerity campaign. Tried to get into this thing from the right side, and many catheters and many attempts later, I said, oh, the heck with it. We went on the left. We were going in the left anyway. And the Simmons, this is a Simmons, Simmons 1, that just sat right in there. And we actually embolized it through the Simmons 1. This is a combination of interlock detachable coils and Nestor coils. This is the ranging angiogram to get the sizing and lengths. It's really interesting always to see how the Lunderquist wires ride through the aneurysm. So here's the top, and the neck's actually really quite beautiful. Aneurysm, a twist and a narrowing, and then if you look on the other side, you see there's a little ulceration right at the bifurcation, and that pesky previously placed stent graft still isn't fully expanded. So we went up, we popped the crown. This is right after you deploy it. Then there's this dot and that dot are a balloon. You slide the balloon up and you blow it up, and that expands the crown to fully seat it. There's the crown open. And then you fish the gates. This is the polymer, the radio-opaque polymer, filling the sealing rings and outlining the legs, the gates that you have to fish. So while the polymer is setting, you get in both of the gates and get your wires up. And here we are, we're up, and we put a pigtail up, and we're measuring to see how long the left limb should be. Obviously, we want to land down here. And we wanted to land right here. We measured and deployed the limb, and it actually took two pieces, one piece and then to here, and then a piece from here down to there. So that's the left limb. And then we went to the right side, did a very similar thing, inject the sheath with a pigtail up, figure out the length, and our goal was to land kind of in here where the taper was. We went up, we deployed the body. For those of you who haven't seen one of these are the indentations of the sealing rings right here and right here. The body, which looked a little narrowed, but then the limbs, and then we let it run a little bit, and we had leaks. We did know there was a left common femoral aneurysm when we started. So when we watched the flow, we thought this was actually a 1B leak as we watched it flow down, because it's not leaking here really. It come down, and we pretty sure we convinced ourselves it was flowing back up. And this is a 3 with the overlap zone. So we thought we'd go in and we would balloon this and try to get it to expand. And we did. And we started to inject, and now it's still got this funny configuration, and it's still leaking like a sieve. So we looked at this a bunch of different ways and tried to, and convinced ourselves that this was still a 1B. And so we actually extended this down with another Viabon. So we stuck a Viabon in, we dilated it, and it looked like that. And now we were saying, okay, maybe it's not a 1B. So I put a catheter actually in the limb and injected. And you can see a little jet right there. And it's a 3. We couldn't figure quite out how we had ended up with a 3. So we had now we've already had a 1B. There's a 3 on the left. There's now a 3 on the right. And we said, fine, we'll go up and we'll reline this. But we had trouble getting the catheters back up through both limbs. That was presumed to be due to kinking in the leg fabric, because if you remember, you go back, there's no metal there. It's all fabric. And so we thought we'd iron it out. We eventually got balloons up there, and we just did a little kissing balloon inflation in the fabric where the legs come together to try to get it out. And then we didn't have too much trouble, and we laid in a new limb inside this, so it's a limb in a limb, which is in a limb which has a viabond extending it. And we said, hey, that's also great. And we let it run a little bit, and we realized that while we had ballooned it, we had changed the alignment of the graft, and we had now pulled the limb that used to be down here up. So now we had a 1B, iatrogenic 1B on the left. So we went and decided we would extend that down. And we did. We popped another graft in, and we went and did another run. And now we have a 1A. So here's the ceiling rings, and here's contrast flowing around the ceiling rings into the aneurysm. And we've still got a leak down here, or there's a new leak down here. And so about all you can do with these grafts, there's only two things you can do. You can dilate the crown again to try to push the ceiling rings back out, which we did. And that was a prolonged inflation. And then we put the pigtail back up and did a run, and that did nothing. And so now it's just running right around the ceiling ring. So there's only one other cure for this, which doesn't involve opening the patient. And that's putting in a Palmaz. So here's the Palmaz XL 4010 going up on the balloon. And you squeeze that thing out and squash the ceiling rings into the aortic wall. And now we've sealed our 1A. Here's the Palmaz. So we say, yay. And we went and did a run. And that looks awesome. Because remember, we extended this side. And now there's all these collaterals, lumbars. And now there's a type 2. And it just kind of flowed here and flowed down along the graft. There may actually still be was potentially a 3 here that we couldn't find. At this point, we decided that it was a type 2. The patient was still fully anticoagulated, and we decided to pull and check on a 1-month CT. We gave the patient protamine and got hemostasis. We had pre-closed it with 2 percloses on each side. We actually needed a 3rd one on each side to get hemostasis. And so this is the, that's the comet, NEOWISE. And these lines right here are our friendly Starlink satellites destroying my sky, the nighttime sky photographs. They're even worse now. I've never actually had a EVAR where we had type 1A, 1B, 2 and 3 all in the same case before. So I think that was just an interesting case, troubleshooting and trouble.
Well, thank you, Neil. It's exhausting listening to that. It sounds like a very challenging case to do.
It started at 8 o'clock in the morning and ended at 2. So these things are, you know, they've made these devices a lot more exciting and a lot more technologically advanced, and it's still a mechanical connection, right? This is still friction and outward pressure, and that's all that holds all these things together.
Okay. Any questions for Dr. Halen? Okay, then with that, we'll wrap it up. Thank you again, Dr. Padia. Excellent talk. I think I learned a lot. I'm sure we all did. So really appreciate you taking the time this evening with you and your daughter to present to us. So
Thanks again. Thanks for the invite.
She's beautiful.
and
Bye, guys.
hi.
Oh,
Yeah.
wow.
And I'll just briefly mention in December 7th at 7 p.m. we'll have our next session. it's a little bit different. We have two presenters who will kind of split, and then we'll have maybe extra time for questions and answers. It'll be Jeff Hall, who created Ellipsis, and Lindsay McCon, who created drug-eluting stents. And they'll be talking about innovation and device creation in IR. So thanks, Dr. Padia. Thanks to all of our case presenters. Congrats to Jaleel. And that's it for this evening.